Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good morning. Thank you for joining us for this live webinar to help you prepare for upcoming changes associated with the implementation of patient-driven groupings model. Today, we will address the importance of aligning agency operations with financial indicators to ensure financial health and a seamless transition to PDGM. My name is Stephanie People. I'm our Senior Director of Brand Marketing here at Axxess. So before we get started, let me tell you a little bit about Axxess. We are a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from industry expert Raymond Bells. Raymond is Managing Consultant with BKD and a member of BKD National Healthcare Group, specializing in home care and hospice financial and operational consulting services. He assists home care and hospice providers with operational strategies related to advanced payment models, defining and implementing successful operational processes, and utilizing electronic medical record systems while focusing on operations process improvement. Joining Raymond is Tammy Ross, Senior Vice President of Professional Services here at Axxess. She leads a team of professionals that's goal is to provide practical operational solutions to home health, hospice, and home care agencies. Tammy has over 30 years of home health experience and has been a senior executive of a large national home health agency. Also joining us today is David Hoover, Vice President of Revenue Cycle Management for Axxess. He leads the company's billing, electronic data interchange, or EDI, and payer management service teams. Prior to joining Axxess, David served in leadership roles at Cotiviti, where he developed new processes and systems focused on increased efficiency and quality in auditing, recovery, and development services. Before we get started, I just have a couple of quick housekeeping items. So everyone's phones are muted. However, you are able to submit questions throughout the webinar. If time permits, presenters will answer as many questions as possible at the end of the webinar today. And if we don't have time to answer all your questions, we will follow up with you following the webinar to make sure that we address every question that comes in. Also, at the end of the webinar, we will be sending out today a link to the slides, and then we will also be posting a recording of this webinar on our website, axxess.com/on-demand. All right, and with that, we'll go ahead and kick it off with Raymond.
All right, thanks, Stephanie. All right, so what we hope you gather out of this information today is alignment for PDGM across your organization. This regulatory change affects each piece of your organization from intake right on through billing, and we just feel like the alignment has to be there across the organization to equal the success that it's going to be. So overall, we hope you take some items away from the webinar that'll help you with your strategy and planning. So what we're going to do is we're going to spend some time giving you a little bit of background on PDGM. We're going to then talk about the payment elements. We'll talk about potential impact in your organization and show you some sampling data elements that's been gathered. And then we'll talk about operational considerations, some strategies that you can use within your organization as you prepare for PDGM in 2020. So really, basically, the background of PDGM is that we're going to remove the biggest piece is we're removing the utilization of the therapy utilization requirements coming out. We're going to be moving to a 30-day payment period, and that was all finalized in the payment rule that was effective January 1st of 2019. And as you know, I'm pretty sure PDGM goes into effect January 1st of 2020. So before we dig into the impacts and some considerations, it's important to take a look at what's making up the home health resource group. There's 4 key elements that make up this resource group. The admission source and timing. You'll have either community institutional, and then you'll have either community early late or institutional early late. You'll have the clinical groupings, which are made up of 12 clinical groupings from the principal diagnosis that's reported on the claim. I think that's important too. Step back here a minute. The admission source and timing will be pulled from the claim, as well as the clinical groupings will be pulled from the claim or from claims. And then the third area is the functional impairment level, which is pulled from the OASIS item set, which is no different than it is in today's model, but it is the only item in the home health resource group that will be pulled from a payment perspective or to help calculate the payment rate from the OASIS. And then we have the comorbidity adjustments, which is from the secondary diagnosis reported on the claim. All to make up, those 4 items will make up the case mix weight, which there will be 453 case mix weights. And probably important to know, outside of the 453 case mix weight, each of those will carry their own LUPA threshold between 2 and 6 visits, which certainly then all of those components make up the national standard rate. This is really just a sampling, start you to think as we talk through the impact and the operational strategies. The clinical groupings, again, this is just a sample of about 5 or 6 states across the industry and what the impact from a clinical groupings perspective is. Basically, this slide is asking you to be thinking about, do you know today what your clinical groupings are made up of? If you took the limited data set that CMS has issued from 2017, do you know what that would look like if you modeled it for 2020? Probably one of the biggest factors to think about here in the slide is if you go to the right, down in the lower right-hand corner, the QEs, which is questionable encounters. Those are those items like general muscle weakness, that basically your claim will be kicked back if it's on the claim as the primary diagnosis, and you'll have to look at those diagnoses and resubmit it back. Then the next area is, again, of high importance, is that functional impairment level. Again, it's no different, driving from the OASIS item set, low, medium, or high. Again, do you know from a diagnosis perspective, if you look at those clinical groupings that are made up in PDGM, you should be thinking about what's that look like, what's the functional scoring look like overall for your organization. Again, this slide is intended to give you just some food for thought around what does that look like from a low, medium, and high, and is there any opportunity as you're looking at your episode management model of how you might influence that coordination from a case management perspective. We'll talk more about that as we move on. So from a PPS versus a PDGM, PPS had one of 3 functional severity levels based on 6 OASIS questions. The difference with PDGM will be there's going to be one of 3 impairment levels, but it's now going to be based on 8 OASIS item set. The 2 additional PDGM OASIS item sets are on the right-hand side. The very first 2, MU 1033, which is risk of hospitalization, and MU 1800, grooming. So those are the 2 additional functional items that'll be part of that, make up that scoring. And then this just is the CMS's estimate from your average 30-day PDGM payment compared to your 30-day equivalent PPS payment period. Again, what does that look like if you took your PPS payment period and put it into 30-day periods? How's that going to align out? And this is how CMS estimated it. The comorbidity adjustment is probably one of the bigger factors to be thinking about as well. Currently, there is no comparable data. This will be new in 2020. So you're going to either have none, low, or high. Again, this is really intended to start giving you some basis to be thinking about. As you see from the data perspective, low and medium certainly have higher percentages. And I think, again, just connecting that dot from the clinical groupings, do you know what that clinical grouping would look like in 2020? And what would that comorbidity, how does that align out? And we're going to talk more about that. But if you think about if you have higher MS rehab or neuro rehab and you have lower comorbidities, it's certainly going to affect the payment. And I think it's just ensuring that that documentation is being reviewed correctly from the get-go. So again, there's no comparative data elements from PPS to PDGM on the comorbidity levels. Basically, there will be none, low, or high from a PDGM perspective. Yeah, none, low adjustment in that. So no adjustment means no other diagnosis on the claim from the qualifying comorbidity subgroups. The low adjustment, other diagnosis on the claim from 1 to 13 comorbidity subgroups. And then the high adjustment is for 2 or more other diagnosis on the claim from 1 of 34 comorbidity subgroups and interactions. It's also important to note we didn't really talk about the overall behavioral adjustment that's still out there. The 6.42% overall behavioral adjustment that could be invoked on organizations. From the comorbidity perspective, 0.38% is coming from that or is aligned to that behavioral adjustment. This is just giving you kind of that breakdown of what that comorbidity subgroup and interaction looks like and kind of how that makes up. I'm not going to spend a lot of time here. And then again, the CMS estimate, the average 30-day PDGM payment compared to the average 30-day equivalent PPS payment. All to really just say, as we dig in now to the impact and some strategies, do you know from an organizational perspective, is there any alignment today of where you are if you're using comparable data or not? And how does that fit into your overall strategy as you prepare your organization moving forward? And I think now I'm going to turn it over to David.
Thanks, Raymond. Great information. And, looking at it from a financial perspective, not only do we want to look at the impact of the change from PPS to PDGM, but we also want to look at potential impacts while we're in PDGM. So first of all, let's take a look at the difference. We took some averages and looked at kind of a median agency and looked at what the potential impact, and we did an analysis, and I think this is good for any agency to have to really understand how PPS looks versus how PDGM looks as a historical perspective, and understanding which pieces of the pie, if you look in the charts, could be changed and led up to the January 1st. Again, in this one, you see 13.4% are showing no payment, which is related to the ungroupable diagnoses. Moving on to once we're in PDGM, you see the first impact or potential impact is with the clinical groupings. And there's really two components. I just mentioned having the ungroupable diagnosis, which in the first example here at the top left, 15.7% of that diagnosis did not create a clinical grouping under PDGM. And in a large agency, which is an example we're showing here, it impacted the agency or will impact the agency about $5 million. So it's significant. And looking at it from just a pure numbers perspective, you see the diagnoses that are out there, 40% of them are considered ungroupable. That's not good odds in my opinion. The other component is not only once you get the primary diagnosis that is groupable, is making sure that the correct diagnosis is used. And what I did here under the clinical group is align the weighted case mixes and the average weighted case mix for each group, and looked at them and said, here's the variance of one diagnosis decision that could impact from all the way from high of the wound care of 1.4 down to the low of surgical care at 1.08. That's 23% variance from one decision. Next, the functional level impact did kind of the same information, or looked at the same information from the case mix weighted average, and looked at the clinical groupings and looked at the decision of low, medium, or high. Again, Raymond discussed about there's two more decision points that need to be made in the functional assessment, plus you have all the different clinical groups now, so it's a much more complicated decision. And looking the difference between low and high in the last column on the right, you'll see that the variance between 0 or high is 28%, all the way down to an average of 26%. So you'll see a variance of significant proportion, you know, for the decision of the functional level. Looking at it from a number perspective or a money perspective, you can see the variance between each group showing moving from low to medium and low to high, each one of the group. The average low to medium variance is about $303, and the average low to high is $507, so significant impact. Comorbidity adjustment impact, the same analysis going by clinical group and looking at the 0, 1, or 2 comorbidity adjustment, and you look at the variance between 0 and 2. It's a little bit tighter than a functional assessment, but basically an average of 17% based on the comorbidity adjustments. Financially, we see, you know, going from a 0 to a 1 equates to about $113, while going from 0 to a 3 is $339. Again, a significant impact on revenue. Raymond also mentioned the LUPA threshold. This is something that's changing, and we will see because we have 30-day billing periods in our 60-day episode. We probably see more frequent LUPA thresholds, and the fact that it has multiple LUPA thresholds based on each grouping makes it a little bit more concerning financially. You can look at the groups of how many HERGs are in each threshold from 2 visits down to 6 visits. You'll see that the most, about 62% of it, are located in a 3 and 4 visit episode. So again, it's not that many visits for it to push into a LUPA threshold. Also, I looked at early and late percentage. Your early is not much of concern, which is what you would think, but the late, definitely, the 2, 3, and 4 make up the majority. Very few LUPA thresholds in the 5 or 6 occur in the second billing period. So to go and look at and using LUPA rates for 2019 for each line of business, you'll also see that we estimated if an average 30-day rate is about a little over $1,700, a 4-nurse visit, which would cause potentially a LUPA, was $586. So you're talking about potentially a revenue loss of almost $1,200. Again, significant. So again, with this, you know, I'll turn it over to Tammy, because from a financial perspective, I can look at all the options that are out there and the decisions that can be made that could affect the revenue. But Tammy, being operational, can help me mitigate some of those and ensure that we're making the right decisions at the right time.
Thanks, David. And just as a poll question, just to think about, the audience to think about, how many of you are meeting with your CFO, your financial managers, you know, bi-weekly, monthly, once a week? I think it's very important as we start prepping for PDGM that we understand what they're seeing on the finance side. They're looking at things in numbers. And then on the operations side, we have to convert those numbers into efficient patient care and still meet those quality objectives. If you'll look at the potential decrease in revenue, no matter what happens, some organizations are going to receive a potential hit in their revenue. And there's things that we can do to start mitigating that potential revenue decrease. If you'll look at the graphic on the right, I showed a operation or a surgery graphic because not many of us would want to go into surgery and have no clue where the surgeon was going to operate on. That just wouldn't be a goal for us. So the same way with home care, we have to have very goal-oriented care, and that includes inter-episode management. We should know best practices, pathways for how many visits it's going to take to accomplish those goals, and obviously involving the patient in those goal settings. The next area where we can look at decreased revenue is reducing turnover rate. It's very expensive to turn over a clinician. So as we go forth with PDGM, properly training and onboarding our staff is going to be very important. Pay models, another consideration. Are we using a pay per visit full-time model? What's our mix of PRN staff to full-time staff? Are we contracting therapy or using in-house therapy? And what is that going to look like with PDGM as we look at possibly a decrease in therapy utilization for many organizations? Mileage reimbursements. Do we have set mileage reimbursements, trip fees? Are we paying the IRS rate? Are we paying a car allowance rate? Maybe it's time to look at getting company cars for certain organizations. Those are all discussions that we should be having with our financial managers at this point and planning for that potential decrease in revenue. Schedule and optimization, using LVNs and PTAs versus RNs and PTs where we can. And do we have an EMR system that supports us being able to run reports and look at schedule and optimization? Supplies and formulary. As you saw from the slides that Raymond and David both presented, wound care is going to pay significantly more with PDGM. This is a very high reimbursed clinical grouping. So as some of us look to develop wound programs, it's going to be very important that we don't have our gross margins eaten into because we're using off formulary and very expensive wound supplies. So partnerships with supply companies also become important. Telehealth, using telehealth in place of visits where it will not make a LUPA happen, may be a consideration of many organizations. And then telehealth can also provide touch points that may actually decrease your LUPA utilization, because generally, you know, using telehealth equipment or even doing telephone touch points, usually a PRN visit will be generated during that episode based on those findings from that touch point. Technology, I have to say your vendor is going to play a very important role in PDGM. What are they doing to assist you with streamlining those operations while at the same time improving your outcomes? And I think it's very important that we look at home health aides again. I've been in the industry almost 30 years and remember when we used home health aides on almost every single case. We got away from that under traditional PPS, but certainly in PDGM, I think they're going to play a more vital role. As we go to the next slide, we're just going to demonstrate that turnover cost from the National Healthcare Retention and RN Staffing Report, $37,000 to $58,000 cost for turning over a nurse. So we certainly want to look at that. As we move to the next slide, we're going to talk a bit about productivity. I think this is very important for us to keep the eye on as we talk about reducing costs under PDGM and actually under PPS. Looking at non-visit time, non-visit documentation time, and again, I'll go back to the EMR, is ease of use so that our clinicians can document efficiently, can document easily in the home using mobile devices, using using a device they're familiar with. This is going to improve their productivity time. Geo-mapping, making sure that we have a way to keep our scheduling geo-mapped so nurses aren't making that long drive time. And this is one of the reasons for turnover in the home health industry. Drive time is significant. I drove from Dallas to San Antonio yesterday, and so I feel their pain with the drive time. That's a lot of time in a car, and some of our nurses, do that 4 or 5 hours of driving in just a couple of days. That's wearing on them. Incentive bonuses. Looking at incentive bonuses for Productivity Plus is a way to ensure good productivity. So are we looking at ways that we reward our very productive staff that go above and beyond? One source documentation, again, that goes along with your vendor and your EMR system. Clinicians shouldn't have to document things more than one time. That's repetitive. That doesn't streamline operations. So if there's one source for documentation, that's going to significantly improve their productivity time. And then looking at integrations, are we integrated in the fact that when we can easily do medication reconciliation? Are supplies integrated? Is it easy to order supplies using your vendor software? These are questions and things that will definitely lead to increased productivity. And just a poll that came out just recently, May 6th actually, from Home Health Line, about a third of the organization are looking to change their productivity standards because of PDGM. I doubt they're going to make them less strict. They're probably going to demand a little bit higher productivity standards to kind of make up those margins they may be losing. We'll go to the next slide. And we'll talk a little bit about functional scoring. We saw that there's real dollars in functional scoring. And looking at Raymond's slide, it looked like Florida had some pretty low functional scores. Maybe that's because they have some very healthy people in Florida. All that sunshine does make you feel good. I think that leads to improved ADLs for sure. Or maybe they just don't know how to score good functionally. We find that nurses score not as well functionally, not as accurately functionally as therapists do. So I certainly suggest inter-rater reliability. We have 5 days we can collaborate on that functional scoring of actually any part of the OASIS, but certainly functional scoring. It's a good time to start letting your PT and nurses go in together or go in a day after each other and compare those scores and start discussing why was questions answered a certain type of way. I always want to say that it's an assessment, not a questionnaire. Nurses tend to question. Therapists tend to actually assess. Get the patient up and walk them. I like to call it a 5-minute oasis. What can you do in 5 minutes to get the most information you can about the ADLs and the functional level of that patient? One thing is to get them out of the chair and actually walk them to their bathroom. See if they can bend down and put on their shoes. If they're diabetic, they need to take them off anyways because we need to check those feet for any diabetic pressure or pressure sores. So watch them actually try to unbutton their shirts. These are some good functional tips that in just a very short amount of time, you can answer quite a few functional scoring questions. If they can't lift their arms, higher than their shoulder level, there's probably a very good chance they're not dressing themselves and are not doing it safely. So looking at those OASIS tips, we need to consider their ability and not their willingness. That's a huge corner in all of our OASIS items. And you can see when you look at the tips, we're assessing. We're not asking them the question. We're actually assessing their ability to do these tasks and to do these tasks safely. Using the OASIS scrubber is certainly indicated so that we can get those inconsistencies quite quickly. And then certainly, knowing that now we're going to be moving to 2 additional questions from the functional scores that we'll be adding into those point values. And we've listed those questions out for you here. Okay, if we'll just go to the next slide. Comorbidity adjustments. I really like what our finance guys said about comorbidity and looking at the numbers there. There's approximately 20% gain that we could have in comorbidity. One important thing to note is claims are going to go from 6 under PPS, secondary diagnosis, to 26 under PDGM. That's significant. We just don't want to throw every secondary diagnosis out there, because remember, we still have to look at treating those secondary diagnoses. You don't need to put it on there unless it's affecting the plan of care, or you're actually going to be working on that diagnosis and actually doing intervention. One thing that we can certainly do is get more information from our referral sources concerning secondary diagnoses. And something to mention here, as we looked at those non-groupable or questionable encounter codes, something to note here, there's not one secondary diagnosis that can be used that's a questionable encounter code. So that means that gait instability and muscle weakness also doesn't work for secondary codes for comorbidity adjustments. So I think it's a really good time that we stop using those questionable encounter codes and we begin using codes that are only PDGM approved. Looking at your software vendor should help you with this. There should be information that tells you which codes are acceptable and which codes are not. If that's not happening now for you, I would encourage you to go ahead and put in a question and a timeline to your software vendor as to when that's going to be available. Looking at our diagnosis subgroupings, subgroupings are considered for a score of low. There are 19 considered for that score and 13 for high. And if we look at the next slide, we'll just break that down a little bit for you. So low comorbidity, we have 13 diagnosis categories. Any one of these diagnoses is going to create a low adjustment. So multiple ones won't create a higher low adjustment, if that makes sense, or more increased revenue. So just by having one secondary diagnosis that falls into one of those 13 categories, it will create that low adjustment. And again, this kind of makes a little bit of a case for chronic care. Medicare recognizes, CMS has recognized the fact that chronic care, multiple comorbidities do cost more to maintain because they're going to require a greater number of resources. As we look at the next slide, we actually give you a few examples of low comorbidity. Now, I'm not a certified coder. I work with a lot of very smart certified coders. They probably know this by heart, but I couldn't tell you what's listed under a cerebral 4 or a circulatory 9. So it's very important for me to have a visual of what falls under those categories. Looking at Heart 10, and I know that arrhythmias fall under that, and 148.3, typical AFib. That's a secondary diagnosis that's going to create that comorbidity example. And we know a lot of our patients have AFib, and AFib certainly plays in and affects many other conditions. So that's probably a good comorbidity example that we would see on a care plan. Also looking at Heart 11, that's our heart failure, hypertensive disease with heart failure. We would expect to see that quite frequently on our plan of cares. And again, I feel like that would fall under, would contribute to those secondary, to that primary diagnosis. Now, neoplasms 1, that's malignant neoplasms of the mouth or throat, as an example. We're probably not going to see a lot of malignant neoplasms at the base of the tongue. Haven't seen a whole lot of that myself in home care, but you could, and that's an example. Now, we only give you some of the example. There's multiple codes that fall under each of these categories, but this will get you started thinking along the lines of comorbidities. And also, it would beg to ask the question, Do I have certified coders that know this information? Is it a good time for me to think about coding partnerships? And looking at our next set of low comorbidity examples, Parkinson's disease, Neuro 5, G20 code. We know we see this quite a bit, as well as diabetic neuropathies under Neuro 10. These are things that we see quite often that's going to lead to that comorbidity revenue add-on. Okay. If we'll go to the next slide, we're going to talk a little bit about our high comorbidities. Now, this gets a little bit more complicated. High comorbidity facts, there's actually 19 subgroupings of these, and these actually have to be grouped in 34 acceptable pairs. About 1,100 diagnoses can be high comorbidity diagnoses. And when we look at this and we start looking at PDGM impact, I just want to point out to you questionable encounter codes up at the top of my graphic here. You can see that this organization has lost quite a bit of money due to questionable encounter codes. This is money that won't pay them for their primary diagnosis, so actually their payment would be zero. But if they used it for their secondary diagnosis, they wouldn't get a comorbid add-on. And a high comorbid add-on, it's a significant amount of money. So we want to be able to capture those high comorbidity diagnoses. So remember, if it's not groupable, if it's a questionable encounter code, it also cannot be used for comorbidity secondary diagnoses under PDGM. So as we look at the next slide, we wanted to give you just a sampling of some of the pairings that you'll see, and why I say your software vendor has to be a partner with you with this, or your coding partner, or your in-house coding. This is just far too much information for most operators and clinicians to have at the top of their memory. Looking at our very first example, you would have to have a diagnosis that came from cerebral 4, such as ischemia or hemiplegia, with the addition of a diagnosis that came from a pairing from heart 10, which would be your AFib and your cardiac arrhythmia. So let me break that down a little bit more. Let's say you have cerebral ischemia from cerebral 4, and you have Parkinson's disease from Neuro 5. It's listed on my sample pairing, but it's not listed together. That's not going to create you a high comorbidity diagnosis pairing. It has to come from the pairing that CMS has grouped that with. So when we look down through here, look at diabetes, look at endocrine 3, it's our third example. Diabetes type 1 or 2, we see that that's an E10.9 code. That would have to be paired with a Neuro 5, a Parkinson's or an MS disease in order to create you a high comorbid diagnosis. Again, there's multiple codes under here. We obviously, for spacing, we couldn't list all 1,100 codes for you, but this gives you an example of how complicated high comorbidity pairing can be and why you're going to need someone probably to assist you with this. Certified coders, coding partnerships, and certainly your EMR vendor can assist you with these pairings. I will point out that many of our pairings, such as UTIs under renal 3, matches up with things that involve skin or wound care. CMS, when they did their impact study and they decided to move to PDGM, one of the drivers and one of the things that they found was that home health in general wasn't taking care of wound care patients as much as they should be. And we all know that. We found out that there wasn't good margins in wound care. So we started pushing, or some agencies started pushing these patients to wound care clinics. CMS wanted to incentivize, so to speak, wound care to occur back in the home. So you'll see that with your comorbidity pairings, that many of your comorbidity pairings relate to wound care or to wounds. So they'll pair something like a neuro or a respiratory with some type of pressure ulcer or stasis ulcer. And you can see that in our last two examples with our renal 3 and our respiratory 5, that those are paired with actually wound care or something that would require wound care. As we go to our next slide, we're going to talk a bit about LUPA adjustments. David presented the slide that there's about $1,100 in missed money in LUPAs. That's a lot of money missed. So if we can avoid LUPAs, we need to avoid those. And there's just some quick tips. First of all, you need to know your LUPA rate. If you're over the national average now, which is around 7.5%, if you're running high LUPA rates now, you're most likely going to run high LUPA rates with PDGM. We predict that LUPA rates are probably going to double with PDGM. So if you're at even 7.5%, you're likely to be at 15% under PDGM. So things that we can do overall, not looking at first billing cycle and second billing cycle, is improve your patient satisfaction score and your hospital and emergent care rates. You don't want to have those patients that you get in 2 or 3 visits and they go straight back to the hospital. Number one, that's not very good for value-based purchasing and ACOs and bundle payments to be able to get you involved in that. But it's also not good for patient care, and it doesn't make your financial people happy. That's when your CFO is going to come to you and say, why do I have all these down codes? I was expecting this much revenue and I'm only getting this much revenue. You also need to know your visit utilization. How many visits per episode are you doing? National average is about 16 visits per episode, and we know some organizations have more, some less, but that's about the national average. And what's your length of stay? If you're an organization that's discharging in 30 days or less, you know automatically that you're not going to get paid for that second episode. If you're discharging in 35 days and only getting a couple of visits in that second 30-day period, you're also going to be creating a LUPA that second 30-day. Let's look at that on the next slide, and this will just give a little bit better example of LUPA's first and second day. Again, we talked about length of stay for your first 30 days. Some PT patients, that's going to be unavoidable. Our hips, our knee patients, you know, they're not homebound after a couple of weeks and they want to go to outpatient PT. I'll call that a non-avoidable LUPA. Using 30-day calendars though, and where you position your actual visits, it's going to be very important. And in a moment, we'll talk about that. Your staffing is important. How are you managing your staff? How are you controlling your missed visits? Are they calling in? Do they have timely documentation? Your second 30 days, looking again at many of the same indicators, but looking at a way, if you're getting to your second 30 days and you're not discharging within the first 30, you may be recerting this patient. So we may want to start looking at telehealth, management and evaluation, maintenance therapy, and just know that first 30-day LUPA, we're seeing that rehab and neuro is the biggest grouping for those LUPAs when we look at PDGM impact. We'll look at the next slide, and this is just going to kind of show you that calendar view. I'm a visual person, been in home care for a long time and actually remember writing these calendars out by hand. And as we look at this, SOC is going to be start of care, SN is your skilled nurse visit, PT is your physical therapy visit, EOB is your end of the billing cycle, because remember we're on 30 days. As we look at the LUPA threshold being 2 to 6, it's going to be very important for you to know that LUPA threshold. And again, looking at 432 LUPAs based on what clinical grouping and HERG rate they're in, you're going to have to rely on your vendors to assist you with that. That's not something that we can easily memorize. Now, most of us have a hard time memorizing 7-digit phone numbers because we have it all on our cell phone. So to memorize 432 different LUPA thresholds, I think would be a stretch. So as we look at this, let's look at a patient that had a LUPA threshold of 6 for the first 30 days and a start of care that was on a Thursday. We see that we had 5 visits in before the patient went to the hospital. 5 visits counting your start of care. And then the patient went to the hospital over the weekend, because that's always when they go to the hospital. They went to the hospital over the weekend, and we had additional visits planned, but that patient was in the hospital. They came out of that hospital on Thursday. So they came out of the hospital on Thursday, the DC from the hospital, and our end of episode was on Friday. Well, what if they came out Thursday night? We didn't have the staffing for Friday. We decided we wasn't going to see them until Saturday. If we did that, if we delayed that hospital resumption of care till Saturday, instead of seeing that patient on Friday, we just cost our organization $1,100. And I'm going to be having David in my office asking me, why is my LUPA rate so high? And in this case, that was an avoidable LUPA. So being able to visualize this and look at this in a calendar view, and knowing that LUPA threshold is going to be vital under PDGM to keep your finance guys happy. Let's look at the second 30 days. And looking at our second 30 days, I want to make a case for chronic care, for being able to recert patients. I think there's a misconception out there that, there's no money after the 30 days because community late pays so poorly. But I want to give you an example of where it can work. If we look at an MMTA cardiac, late episode, community with a low comorbidity and a mid-functional level. And when you think about PDGM and we think about how hard it is to get a high comorbidity, and most of our patients are going to fall probably the biggest percentage into our mid-functional level, this is a pretty standard patient. We have a case mix of a 0.7812. That's roughly about $1,500, a little over $1,471 to be exact. If I use my national LUPA rate as my cost basis, and I look at doing a management and evaluation of care on this particular patient, and looking at my calendar on the right, HHA is going to be your home health aide. TEL is going to be a tele-touch point. And when I say a tele-touch point, this is a telephone call and also incorporating all of your telehealth information in the chart. CMS doesn't look kindly, the physical intermediaries don't look kindly on just 2 visits a month generally from a skilled nurse for M&E. So if we're going to use this, we have to use this correctly and do telephone calls and incorporate that telehealth information into the chart. If we look at this, we are doing 8 home health aide visits at a cost of $66.34 a visit. That's going to total $530.72 for our home health aide. 2 RN visits at $146.50. It's going to total $293. So if we take our cost and we subtract it from our 30-day payment of $1,471, we're going to have $647.28 left over for our margin for this episode. Now, granted, this doesn't include your indirect cost of that telephone call. Hopefully, one of your director of nurses, your clinical managers, your administrators, someone in the office is going to be doing this for you and incorporating that information. But your margin per episode, your gross margin before we subtract indirect costs, is $647.28. That's pretty good gross margin. So looking at that and looking at these patients that are going to be more chronic and maybe be reserted an episode, these patients, there's still money and there's still margins in this. So I want to make that case. And also just for quality care, it takes a bit to establish a rapport with a patient and learn a patient and be able to really drive those goals down. When you're looking at multiple comorbidity and secondary diagnosis, it's very difficult to train and to teach in order to reach those outcomes in 30 days. So not only is it financially a good move, I think it's a great move for outcomes as well, to look at things and think about things more at that 60-day episode period. Let's look at our next slide. Thank you. Questionable encounter codes. So we just want to talk a bit about questionable encounter codes and look at those codes that won't calculate a grouper. We mentioned that a couple of times. The biggest part is you have to be specific. You need software tools. We have to train our referral sources, begin that now. You don't want to start on January 1st asking them for all this additional information. So let's start that training now. The other thing is a lot of organizations are talking about certified document specialists. They use them in the hospital. These people have knowledge in coding, they have knowledge in pathophysiology, they have knowledge in the industry, and they can help guide your referral sources to get you the information you need to be able to code specifically. I'll point you to our graphic. This graphic is actually on our Axxess.com PDGM page. It's free for anybody that wants to go and grab those resources. There's also several other resources available, but this will give you the full list of what we consider the top 25 questionable encounter codes that we saw across our span of about 3,000 agencies. Let's look at the next slide, and this just breaks those codes down for you. And you can see many of these codes are related to that neuro rehab clinical grouping that both Raymond and David mentioned that will not create revenue. You have muscle weakness, ataxic gait, difficulty walking, unsteadiness on feet, repeated falls, history of falls. All of these are related to that non-groupable diagnosis, and I can just see the chart in my mind now that when we looked at that bar chart that Raymond presented, those were like the highest level was these ungroupable diagnoses. So we're really going to have to start working on that and focusing on that today. As we go to our next slide, I will let Raymond summarize for us and then open it up maybe for a few questions.
Thanks, Tammy. Yeah, so a lot of information, probably a little overwhelming, especially if this is the first you've heard about PDGM, which we hope is not. But there are some resources here from both Axxess and BKD. And, you know, as we stated at the beginning, we just hope that your organization really sees the importance of aligning across the operations from intake through billing and cash posting. So we appreciate your time, and I know that Jennifer is going to do a little wrap up here at the end. Thank you.
Thank you, Raymond, Tammy, and David for sharing your wisdom as we prepare for the implementation of PDGM. This was a great webinar giving us incredible insight. We do have just a couple of questions that I'm going to ask, and then you all can address. Everything I've heard says that we should reduce the length of stay. However, how are shorter length of stays impacted by PDGM?
So I'll take that one. I would just say if you're less than 30 days, you're not going to get paid for the second 30 days. So essentially, you're going to cut your revenue in half. Also, depending on how your visits fall and where your length of stay is, if you're at that 38, 39 days, you may be creating a LUPA in that second 30-day period, which again is going to impact your revenue.
Thank you, Tammy. An additional question, for those agencies that are still allowed to submit RAPs, will the agency be paid as they currently are after submitting a RAP, or do they have to wait until they submit the 30-day claim?
I'll take that one. So currently right now, it's just breaking it into 2 billing periods. They will actually act the same way that we have currently. So you'll submit a RAP, you'll get paid on the RAP. You'll submit a final, you'll get paid on the final. And now the timing on that, they'll kind of overlap. You'll actually submit both of your RAPs probably before you get your first final payment, but that's just a timing thing. So there will be a little adjustment in how your cash flow timing works, but it will act the same.
Thank you. All right. Well, thank you, everybody. We appreciate your attendance in today's webinar. I just want to let everybody know that we will be sending out the slides from today's webinar. Many of you have asked questions for the slides, so they will be coming, as well as we'll have a recording of the webinar on our website. In addition to that, some of you have asked for some additional resources. So Raymond mentioned the resources that you can find on our website. If you go to axxess.com/PDGM, you will see many resources that are available for download, some of the unquestionable counter codes, that total list, as well as other very useful resources and tools. If you have any questions, we look forward to hearing from you and seeing you at our next webinar, which we are inviting all of you to join us for our next webinar, Using Data to Drive Success with PDGM, which will feature Aaron Little from BKD, as well as David Merck with Axxess, who is the founder of Home Health Gold. So the webinar will be held on the 27th at 11 a.m. Central, and we'll send out registration details along with the recordings following this webinar. Thank you, everyone. Have a great day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.